So we are live in 5, 4, 3, 2, 1. We are live now.
Yeah. Warm welcome to the 8th session for Pediatric Orthopedic Fellows. I welcome the experts for today's session. That's Ved Shrader. Ved is practicing at Alfred DuPont Hospital, Delaware in USA. And he's the successor of Freeman Miller. Freeman Miller does not need an introduction. We can always say that the person who is equal to a Bible of cerebral palsy. And like Freeman, Ved Shrader is also using gait analysis, 3D gait analysis for the decision making. And so today our focus is mainly on that. Before we go to the topic, let me tell something about Ved. His main focus, 90% of his practice is on related to cerebral palsy. And what is unique about him is that he's a father of two boys or two adults now with cerebral palsy. And because of that, he knows the problem of parents and the family of children with cerebral palsy. His mission statement, which I read on his website, which is full of empathy, and that touches the heart of his patients and the parents, that I know what you are going through, and I am going to do everything in my power to help you to relieve your suffering. So that's exactly what every doctor who is treating children with neuromuscular condition should have, that empathy. And I really appreciate and I really like that. The today's session is going to be on the use of the 3D gait analysis in decision making, and we will be focusing on cerebral palsy. Where to give you the current scenario related to 3D gait analysis, we have around 15 gait laboratories across India, of which the 10 centers, we have a functional gait lab. But fortunately or unfortunately, mainly I should say unfortunately, none of the center having a pediatric orthopedic fellows have this facility available. So most of the fellows today who are going to participate in the session, they are not having this facility. And for them, this is something they are really keen to know about it. And how I equate the situation, suppose I am driving a Honda car and someone has a Mercedes Benz, then you always look for what are the additional features in the Mercedes. So that's going to be the situation for us. So let's start with a very simple question. This is going to be more of an interaction. And in addition, we will be bringing some case discussion also so that we can ask a very relevant question. So Ved, the first question I would like to ask you is that whenever you get a patient with reports of the 3D gait analysis, what do you actually see in that report?
So first of all, I want to thank you all for having me today. It's a great honor and privilege to be with you. As Dhiren mentioned, this topics of CP and improving the care of children with cerebral palsy is certainly near and dear to my heart, and I love talking about it. And so I really appreciate the opportunity to come. As you mentioned, I did take over Dr. Freeman Miller's practice, so I am in that Mercedes-Benz really, and we get the same stares here in the United States because comparatively speaking, we're even in a Maserati compared to a lot of the hospitals around the rest of our country. Freeman, to his legacy, created an incredible infrastructure that was centered on three-dimensional gait analysis. So I have not always had that luxury, though. I helped start the Phoenix Children's CP program out in Arizona, out in the desert in the western part of the United States. And for years, I didn't have a gait lab. And so I've been able to kind of live both worlds. And so I hope you'll find as we talk today that I'm able to give a fairly balanced perspective on that. So what are we looking for in the reports? So, I mean, we get reports from other gait labs as well. our report here has been honed over the years by Freeman's judgment and a little bit of our different input as we've kind of come on over the last 5 years since Freeman retired and modified it there. I think the first thing that we always see when we talk about a gait analysis is we want to see that there has been an adequate visual gait analysis with just video and an observational gait analysis based on that. That's the first thing that I want to see, because that's the things that we're seeing based on our eyes, and more than likely that's the thing that the parents are seeing too. Right after that section, we have what I want to hear or I want to find is I want to see what the parents' complaints are. I think we are in a process and an evolution in healthcare where we're definitely shifting towards more family-centered care, and Uni Narayanan has worked really significantly on trying to the new goal questionnaire of trying to ask parents and family members what is important to them and what would they improve upon if they could. So we ask similar sorts of questions in our gait lab. And so those are the first two things that I really spend some time on, because I really want to focus on that, because I think that kind of sets the stage for everything else. The kinematics and the kinetics and the EMG, and we also do foot pedobarograph and even some oxygen consumption measurements. All those things are very sophisticated, and they sometimes will find things that are small abnormalities or impairments, but that doesn't mean that those things are always clinically important to the families. So those are the first things that I look at. And then we switch over to the temporal distance parameters, things of speed and cadence and step length and stride length and step width. And we calculate gait deviation index, which is a single number that's based on the kinematics. We can talk about that a little bit later if we want. And then we have organized plots of kinematics first, followed by kinetics. Kinematics, of course, is the angular measurements of all of the different joint segments, including the pelvis, which I think the pelvis and trunk is very important to look at. And then we have similar stacked plots for kinetics. And then we have kind of traditional combined plots where you can look at it across the joint. So if you have different visualizations that you're trying to do, then usually we follow that with EMG and pedobarograph. And then I like to see, most clinical gait laboratories will have a clinical interpretation then down at the bottom of what surgical recommendations may be considered. I always like to say, though, that just like a radiologist reads MRIs scans, right? A good orthopedic surgeon doesn't always just take for granted what the radiologist reading is for that MRI report. They look at the images themselves. And so I think, although gait labs are a little bit different because not everybody has that same expertise and familiarity looking at them, but I think you should, even if you're taking that gait lab report, even from a different organization, you should still go through the recommendations and make sure, A, you agree with them, make sure they make sense to you. And then also, do they match what the parents' goals are up there, or the family goals, to make sure about that. So we spend a good bit of time talking about that, trying to go through and make sure that what we're recommending and what we're finding from the biomechanical analysis matches what the parents are thinking. And if there's a disconnect there, we spend extra time kind of digging through that, because if there is a disconnect there, I found most of the time the families aren't very happy with the post-operative state, right? If they're really worried about their feet and how their feet look, for instance, but they're really not as worried about their rotation in their femurs. If we do a femoral osteotomy, they may not be as happy about that.
Okay. Then, as you say that there are a lot of things in the 3D gait analysis report: kinematics, kinetics, oxygen consumption, pedography, EMG. So which one really you use? Like, I'm really keen to know about how do you use kinetics.
Yeah.
Kinematics, yes, we all know it's a representation of the video analysis, but kinetics is like the one where we are really trying to understand how it helps in decision making.
I think that's a great question too. And I'm an engineer by training, so I love the kinetics. I love looking at the moments. I love looking at the powers that we do. I can tell you, our mainstay, I think, like most gait analyses, is looking at the kinematics, looking at the angular measurements, right? That's what we see. That's what the families see. And I think those are the things that I think we have as orthopedic surgeons, the power mostly to correct, really. The things about the moments on the kinetics, looking at the forces acting on the joints and everything, that comes into, there's a lot of other aspects of cerebral palsy that come into play for that, including weakness and lack of selective motor control, right? That's different than the angles, and those things play into the angles as well. But I think there, especially the weakness thing, there is only so much that we can do for orthopedics that can really affect some of those things. So I'm very specific in what I look at in the kinetics. On the hip, there's two things that we look at mostly, is if we see really significant hip extension moments, then I know that hip's in a lot of flexion. And then that's the internal moment that's kind of countering that and trying to do that. And I know that's just kind of plays into a little bit of my mind about trying to decide about dose in crouch gait surgery, which I know we're going to talk about a little bit lower. The other thing that I find interesting too on the hips is looking at the hip abduction moment. And there's not a lot I don't think that we can do about that. I haven't been really impressed that I use that as clinical judgment, as decision making, but it gives me a little bit of a idea about the hip abductor weakness and how much Trendelenburg gait they have, and how much that may not ever go away in terms of any surgical treatment, and obviously to give the therapist to talk about that. The ankle also gives you interesting information where you can see a double bump pattern of ankle spasticity and an early plantar flexion moment. But again, I think you always find that similar sorts of information of an equinus pattern in the kinematics. So I don't know that those really, neither one of those, I find them interesting, and I always comment on them. The one that I really kind of helped me make decision making is the knee kinetics. So again, back to the crouch gait example. I'm really bothered when I see really high extension moments on the knee kinetics. And if you're in crouch gait, you're going to have high extension moments because the knee's trying to balance out that big knee flexion angular position. But I worry about the loads on the knee over time, especially loads on the patellofemoral joint. So if it's mildly elevated, that's probably acceptable. But if we start to get really high outside our bounds, that kind of pushes me a little bit more to really be thinking about that we need to do something about their crouch gait. Similarly, and I think this was, the whole phenomena about the plantar flexion knee extension moment and couple, I think really we've learned more about that through gait analysis. So I think that's one of the legacies of three-dimensional gait analysis, and specifically the group Jim Gage and the group at Gillette, Tom Novacek and all. When you have a significant external tibial torsion, internal femoral rotation, and plano valgus foot, which is a very typical pattern in spastic diplegia, usually you'll have really significant knee varus moments. And also, some kids tolerate that rotation fairly well and don't have big moments. But if they do have big moments, I usually will use that and show the parents, and I'm concerned about what those moments would do loading the knee in the future. And to me, that is an indication to really consider doing transverse plane surgery or trying to do the derotations of the femur and the tibia.
Before I ask Dr. Nirmal to ask a further question, I just would like to understand from you. Let's take this is a lower limb. This is, let's take it a pelvis.
Okay,
Now, if my knee is bent,
right,
so naturally, the primary problem is at the knee, but
right,
now the hip is also looking like it's a flex.
exactly.
So now how do you differentiate this situation? Because like on kinematics, we cannot differentiate whether the primary problem is at the hip or primary problem is at the knee. So in that case, how do you find out that whether the hip problem is the cause or is the effect?
That is an excellent question. And I don't think any of us really have the true answer to be able to do that. Our crouch gait protocol, if you will, of how we, our recipe and approach to treating kids with crouch gait, I think continues to evolve because I don't think we have a great solution for it. In your example, the kinetics, you're exactly right. As you showed that bent knee, the ground reaction force is going to be behind the knee. So there is going to be from Newton's third law, and that's what the force plate measures. It's going to have an external knee flexion moment because of the ground reaction force, right? So we're going to measure high extension moments because that's what's balancing it. It's measuring the internal moments, and that's what we report. But you don't know where the main pathophysiology is. So, that's where, for me, I go back to my kinematics and I look at my pelvic tilt is the main thing that I look at. And because I'm driving that both my pelvic tilt as well as my physical exam to try to get a measure of how big of contracture my hip flexion contracture is. Now, following kind of my legacy of Freeman probably did not do as much psoas surgery as what they do in Gillette. Gillette does a lot of psoas surgery, a lot of psoas lengthenings over the brim. And Freeman never did do a lot of that. And the main reason why he didn't was he found that the rehab was so hard for those kids that he felt like it was almost a little bit, a futile surgery. You do a psoas lengthening, you really need to have those kids stretched in prone and extension to try to stretch it and get the effect, especially when you do a myofascial lengthening, right? Where you're just lengthening the tendon and letting the rest of the muscle go. If you sit in a flex position for the next 6 weeks, that's going to scar down pretty much at the same length. And I really took that it made a lot of sense to me. And when I tried to do a lot of prone rehab for these kids, it was very, very difficult. We had a very hard time getting the families to cooperate. So we kind of follow on that. So what we usually use is our Thomas test and really try to measure our hip flexion contracture, looking at the anterior pelvic tilt to make a decision about hamstring lengthening or not. I think that is a key measure about that. And then try to put all of those things together to try to come up with that. I got to say, I usually focus on the knee because I think that is the area that I can affect more change than I can at the hip and the pelvis, typically in the sagittal plane. I think a lot of these kids, once they get some anterior pelvic tilt, they get a fairly fixed pelvic incidence with that compensatory lumbar lordosis that is not really that significantly modifiable with soft tissue surgery alone.
Okay. Yeah, over to you, Nirmal Raj, please.
Yeah, thank you, sir. And it was right to say that there is a limited availability of 3D gait analysis all over the country, actually. And there is a constant denial that it is a mandatory thing to have the decision making. So my question, sir, is what additional information does 3D gait analysis give you in addition to your clinical examination and video gait analysis? And can you give it as an example that what we are getting more from it?
Yeah, I'm happy to kind of talk a little bit about this because we face those same questions, right? There's a ton of places around the United States. There's a lot of our fellowship programs around the United States that may have a lab, but it's not a significant part of their educational process. Boston Children's and CHOP, for instance, those are two of the top fellowship programs in the United States, and they don't have labs as a regular part of their clinical care or their fellows education. So that question, I think, comes up a lot. And I think it comes up a lot when we have to justify the existence of the gait labs as well. So I think the first obvious example that I think that we see that the gait lab highlights more, and this is both good and bad, is rectus femoris dysfunction. We visually see kids that have fairly stiff gait, but but that's not always that significant to the families, right? If they're dragging, then that's one thing. If they're dragging and they're not able to clear their foot, that's a complaint that families will get. But that's something that we can usually kind of affect a little bit with some foot or ankle surgery. But the stiff knee gait primarily has been a gait lab diagnosis from rectus dysfunction. Obviously, we do the Eli test and we get physical exam measurements and we ask the families if they're dragging or tripping, but it primarily is we look at rectus on EMG. I'm sorry, I didn't finish that question before. When we look at EMG data, the primary thing that I'm looking at on that is looking for rectus dysfunction, is what we're looking for. That we're looking for rectus femoris firing out of phase. So that's one thing we see in addition to the physical exam. But we also look at the kinematics, and we look at that decreased peak knee flexion and a delayed peak knee flexion. So, so that's one thing. If you look back, there's probably been as much written about rectus surgery as anything in ambulatory CP, but yet we're still trying to find the right indications. We do a lot of rectus surgery based on those plots, but I'm not sure we see a lot of bang for our buck functional outcomes from that. So, I think that's driven us a lot to be really critical about the rectus surgery, looking at transfers versus just releases. And we found in multiple studies, including one from here, that it's the same. If you just release it, it's the same as doing that, as doing a transfer with a more complex thing. So I think rectus surgery is one of those things that the gait lab finds. I'm not sure that's always a good thing, because sometimes we operate on that when it's maybe not as big of an important problem. It's a gait lab diagnosis. I think the best benefit that I think from the gait lab is really when you have a lot of significant transverse plane abnormalities in an asymmetric diplegic, or a hemiplegic that has, that really, we've called them a hemiplegic, but they might have just a little bit of touch on that other side. I think when you get asymmetric tone and motor control issues in the lower extremity, and you start getting a lot of rotational abnormalities, especially with the pelvis, that is very hard to pick up with just your eyes. And so, obviously, kids have shorts on they have things, they have clothes. We try to get them down with just shorts and a light top in order to get better marker placement and to get better visualization of their different bony prominences. But obviously we're not testing these kids completely unclothed. They're not naked. So seeing their pelvis sometimes I think is very, very hard. And trying to measure the relative accumulation. So for instance, somebody might have a lot of internal femoral rotation, but if they have pelvic retraction, those things may cancel each other out, and visually you may not see that as much. So I think complex transverse plane is definitely something the gait lab adds to that. And it's probably the one area that someone who's just relying on visual gait analysis, they might get tripped up a little bit, and that might cause some errors. Now, how often does that happen? I run a gait lab, right? We bill for the gait lab services. We bill insurance. So it's important that our insurance companies continue to pay us so that we can keep our gait lab opening and flourishing, because we do a lot of research on the side with that as well. But ultimately, if you really kind of said, Wade, how many times do you think a gait lab is just absolutely necessary? Before I came to DuPont, I probably would have said 20% is what I would have said. I would have said that a lot of things, a typical true Aquinas gait as a gait pattern, you probably don't gain a ton of information from that full analysis that you couldn't get from just a good physical exam and a good video. And that is one thing that I do think that we should highlight whenever we talk about this, is that, you know, in today's world with our phones and our iPads, that we can get really good videos in our clinic, and then you can save those videos. That's come a long, long way. So doing a very systematic, saving good video and doing a good systematic observational gait analysis, I think is a really, really high quality solution when you don't have access to a three-dimensional gait study.
Thank you, sir. So you're muted, Dr. Dhiren.
Yeah, so the next question is by Dr. Hitesh. Hitesh is a professor at Kasturba Medical College, which is one of the prime institute for pediatric orthopedics. And he's going to ask another important practical question. Yeah, over to you, Hitesh.
Yeah, thank you, Dhiren bhai. Thank you for the giving said. Thank you, Dr. Wade. That's the question is there, how 3D gait analysis helps in fine-tuning decision-making for hamstring, calf, psoas, and rectus, all the soft tissue surgery.
Yeah, that's a great, Hitesh. Thank you for that question. That's a great question. And I think it has actually improved our ability when we're thinking about that. I think, you know, hamstring surgery in particular is the one area that you know, you see kids, you see that their hamstrings are tight, their popliteal angle is tight, they're walking with a knee flexion gait. It's natural to think about, well, I've got to lengthen their hamstrings, and if I've lengthened them in the past and then they come back again with recurrence, which is incredibly common for all of us, we might think about doing it again and again, because that's the only tool that we have really we think about is lengthening that tendon, right? So I think three-dimensional gait analysis has been very fundamental in that, in thinking about the overall length of the hamstrings, even if you don't do overt muscle length modeling, which we don't, but we do measure pelvic tilt. If we have a significant amount of anterior pelvic tilt, you know, that cautions us from thinking about doing anything of touching the hamstrings, because already, right, we think that theoretically, at least our hamstrings are already plenty long. So I think then we have to start thinking about either other sources of the crouch, like the hip and the psoas, or is it just pure quad insufficiency and the hamstrings is really not going to be able to give us a big enough dose for that. I think, you know, the knowledge about about the contribution of the iatrogenic contribution of Achilles tendon lengthening on crouch gait has been fundamental as well. I do really feel like that has kind of changed the world in the last 20 years, from where even when I started training about lots of PERT TALs, because families come to you, again, you're as an orthopedic surgeon, not really looking and you know, what the Gait Lab does is it forces you to think about the biomechanics at the other segments. You know, you have to, because it's laid out like that. And so, you know, oftentimes, you know, well-meaning doctors all over the world would see a kid coming in walking on their toes and they'd lengthen their Achilles tendons, not really thinking about the downstream effects later from an over-lengthened heel cord. So I think that has revolutionized us there. And I think the Gait Lab gives us a little bit of information about how to guide that dose too, about plantar flexion lengthening, to make sure that we don't over lengthen it. We talked a little bit about rectus before. I do guide, for it to be worthwhile to do rectus surgery, I have to kind of be hitting on all those things. I need to have really some symptoms from the family that this is really significantly causing problems. I need to have physical exam. And then I really need confirmatory findings on both kinematics and EMG that it's the rectus problem. Because I think there's a lot of times there is some co-contracture of our vastus medialis and lateralis, and it's not always rectus spasticity that's causing the stiff-kneed gait. And so I think for me to pull the trigger on rectus, I need all of those things. So I think really it is really fundamental for that we have the Gait lab. And then we talked about the hip before a little bit. I think, hip kinematics, I think are important, but I don't use that a lot in my judgment, because if I, as Dhiren said before, we can see a lot of knee flexion, but it may be driven by the hip. And vice versa. If we have a lot of knee flexion, we're going to have a lot of hip flexion as well. And that may not be pathologic. So I really try to rely on my physical exam for that. And I tolerate small hip flexion contractures of 10 to 15, and occasionally maybe even up to 20 degrees. But if we get a hip flexion contractures at 25 or 30 degrees, that's when we're doing the psoas lengthening as well.
But I would just like to ask more specifically, like what you said, you explained really well that gait analysis help you to decide whether to go for a particular surgery or not. But if we really want to decide or like ask about the dose of surgery, like say, let me give you an example. If we talk of a hamstring, then we have medial and lateral hamstring surgery on the maximum side. Then we have only medial hamstrings. Then we have only semi-T release. And then we have the minimum dose is semi-T transfer. So there is a wide spectrum. Does gait analysis really help you to decide how much dose you want to give, or it's more on a personal understanding of the hamstring surgery that decides the dose?
Dhiren, very good question. Yeah. So I think it does impact. I think it does. The dose certainly does enter our minds now, and more than it did, even 10 years ago. And so I think that it is there. I would say that probably the clinical judgment and philosophy of a given surgeon or center probably weighs more into that than not. And I'll give you a couple of examples about that. Freeman used to do a lot of lateral hamstring lengthenings. He really did. And we're in the process of starting to look at that. It didn't always cause increased anterior pelvic tilt. We have lots of cases here that it did not. And so we're trying to look at those cases to understand that a little bit. But I would say, I think in general, I have been impressed by, Mike Schwartz's modeling and things from Gillette, that we have moved away from doing any lateral hamstring lengthening, except in only the most severe cases. So that to go to that highest dose that you said, we would use the kinematics to help guide that if it really, really is significant about that. And I would say we probably do that only less than 5% of the time, not very often. Then down on the lower dose of things, I would say our kind of go-to is to do semi-T and gracilis lengthening and a fractional lengthening of semimembranosus. That's our standard medial hamstring lengthening. We would back off on that if we saw just very mild or borderline increase in our kinematics and our knee flexion at initial contact and at mid stance. If we're seeing just a little bit of knee flexion, we might not do all three of those. We might just do, as you said, just semi-T and just lengthen for that. But most of the time we'd do all three. But if we see that, so I do think it guides us a little bit. We have not done the transfer here. And we've not done it because I think there's a little bit of some conflicting evidence right now. The group out of South America really did not showed that there was no difference when compared with hamstring surgery. Our feeling after having done years and years of rectus transfers is that, those transfers probably aren't any more effective than doing just the releases or the tenotomies or the lengthenings. And as I said, Freeman has some experience here where, and we have, there are some very interesting cases where I'm not sure, where really we didn't see a really increase in the pelvic tilt. So I'm not sure that it's really that big a bang for the buck. So we've not done the transfers.
So if I give analogy, like the standard practice is to give 10 milligram of ibuprofen per kilogram for the pain relief.
Yeah.
Now, like the Freeman is on the side of giving a 10 milligram per kilogram.
Right.
Then you may be, or I'm in the like giving 8 milligram dosage. Like
Right.
I believe only in the medial hamstring. On
Yep.
the other end, there is a like our common friend, the Paulo Salber. He says that the only dose, appropriate dose for the hamstring surgery is the semi-T transfer, nothing more than that. So
Yep.
these are basically the good people, the expert people. So it's more of a personal philosophy which matters more than the kinematics or the kinetics. Is it?
I think right now that's true because that's the level of our evidence, right? And, you know, like we've talked to Paulo is now in New York. Jason and I have talked to him about us trying to do a study together where we truly do a randomized trial, or at least a cohort comparison, to try to isolate out really what is the effect of that transfer, so that we can truly measure in as high quality study as we can. Is it actually changing your pelvic tilt? The only thing that I would say about Paulo, and it'll be interesting to see if he's still practicing in the United States in 10 years from now. Does he have a difference or not? You know, in Australia, they have a incredibly high quality access to physical therapy. You know, those kids have a uniform access to therapy, and neglected kids, you know, where they haven't had therapy and they haven't had orthopedic attention, really just are not that, you know, they're just not, they don't happen in Australia really. I would imagine that they happen a good bit in your country, and they happen a good bit in our country, actually, sadly, as much of resourced as we are. We see kids all the time that basically get zero therapy, you know, up till age 12. You know, our therapy is based in our school systems, and they literally might get 15 minutes a week. And the socioeconomics of most of these families are not such that they're bringing their kids for healthcare. And so, you know, we truly do see kids that are so severe that I think it's a bit of apples and oranges comparing systems across the world. I think that happens with the crouch gait too, where, you know, if you stretch kids enough and get enough quad strengthening and you prevent contractures, then you probably don't have to do a lot of big crouch gait surgery. And I think that's what their experience has been in Australia, where with us, it's very routine that we see kids who are ambulatory kids who walk in our office, hasn't seen orthopedics in 10 years. And, you know, they have 30 and 40 degree knee flexion contractures. I mean, that's just routine, even in our biggest metropolitan areas. So I think that's a big part of that. So yes, I think if you're in a incredibly resourced area where you're getting really high quality, high fidelity therapy, maybe only these low dose procedures, there probably would be enough.
Nirmal, the next question by you.
Yeah. So this question is again in continuity with the limited availability of 3D gait analysis across our country. So, sir, can you tell us in what percentage do we err if we don't use a 3D gait analysis and we only rely upon our clinical examination and visual gait analysis? And what are those errors that can happen if we don't use a 3D gait analysis?
Yeah, one of the classic examples that we have here out of DuPont is that situation that I mentioned before, where it's an asymmetric diplegic. Really, people had called them a hemiplegic in the past, and they had so much pelvic rotation. So they had a unilateral significant femoral anteversion, and they were compensating so much for that visually it looked like the other side was internally rotated. And so we had seen this kid before, and so we had recommended a unilateral femoral rotation, derotation, to try to correct the deformity and then correct that pelvis compensation. And they went to another facility, and they had a derotation on the opposite leg, right? And so, you know, so obviously that, you know, in that situation, that other center ignored our gait lab recommendations. And that particular center probably just wasn't spending enough time to really think about all the different biomechanical segments. So so that kid came back to us worse, actually. So now it's externally rotated. So they were even, their pelvic rotation in terms of their overall forward velocity had worsened with the contralateral derotation because it made everything worse. So I think that is the situation where there's that pitfall. So how often does that happen? Probably 5 or 10% of the time. I think that could be avoided, you know, without even a gait analysis, just a very thorough evaluation and a systematic observational gait analysis, where you could really not only, you know, obviously visualize what appears to be the affected leg, but a bilateral systematic evaluation with a good physical exam, like everything right off the bat. And then for this case, you'd probably, you know, I think a good video analysis probably would be able to pick that up. But it was a hard case, actually. When you looked at it visually, your eyes were so drawn to that right side that you didn't really, and she was a little bit of a bigger kid. And so, you know, it was hard to really see her pelvic landmarks and all. But I think that is actually the one case. I think if you don't have a gait lab, you'll probably do less rectus surgery, as I said before, but I don't know that that's necessarily a bad thing. Because I think sometimes we probably do a little bit too much gait analysis for that, and too much rectus surgery for that. But I think it's the transverse plane things, which is the biggest thing. But I think you can overcome it with really, like I said, John David's out in the Sacramento Shrine has done a couple of series, and one of the articles is in Jay Posna about how to do gait analysis without a 3-dimensional gait lab. And it gives you some practical hints in there. He's got a PDF of his talk that you can download as well off their website in the Sacramento Shrine, Northern California Shriners Hospital. And John David's, he actually has some practicalities of how to do some video even from your phone, you know, and some standard views and how long you need and kind of distances to try to set up. A little bit about how to name the files to keep track of it all. And then going through like an Edinburgh visual gait score, just a systematic way of looking at it. And I think if you did that, then you could really probably, you could counter, you know, the weaknesses of not having one.
Well, the next thing is something going to be like whenever there is a new procedure, the science asks for a comparative study. That what is the new technique, better, same, or the poorer than the existing technique. So we are going to do almost the same thing over here for the gait analysis. So I will tell you, I'm going to show a video of a girl who is 13-year-old GMFCS level 3 to 4 experts which we have from India, Dr. Nirmal, Dr. Hitesh, Dr. Thomas, and Dr. Taral. So they will say from this video what abnormality they found.
That sounds great. Yeah.
And
perfect.
after that, I will show you the 3D gait analysis report of the same girl to you to find out like what more things you tell us what these experts from India are not able to identify on the video gait analysis.
Sounds
right.
good.
So let's go for
Perfect.
this interesting exercise.
That'd be good. Yeah.
Yeah. Yeah, just a minute.
No problem.
Share screen. Yes, here is the video. Yeah. Yeah, can you see the slides?
Yes.
Yes. So this is a video, a diplegic cerebral palsy child, girl, 13-year-old. She's walking at GMFCS level 3. She had history of hamstring surgery before 5 years. At present, she does not use orthosis during routine walking. We have two sets of video. Okay, and now we go to the video from the back. Okay, so I would like to stop. Let me go further and tell you something about the physical examination. On physical examination of the feet are passively correctable. The dorsiflexion achieved without correcting the foot is up to 10 degrees of dorsiflexion. But once we take the foot into inversion and correct the foot, the dorsiflexion is not possible and the foot remains in 10 degrees of plantar flexion. So that suggests that, yes, there is some element of gastrosoleus shortening. Coming to the knee examination, there is a 15 degree fixed flexion deformity of both the knees. The active knee extension leg is 20 degree on both the sides. The prone rectus test is bilateral positive. On the hip examination, the passive hip extension is 0 degree, means there is no fixed flexion deformity at the hip joint. But yes, the last 10 degree of hip extension is restricted. So now I would like to ask a question to our experts. I will start with Dr. Nirmal Raj. Nirmal Raj, what are the abnormalities which you see in this patient?
Yeah. As per history, she's a spastic paraplegic. So on the video shown from the front and focusing on the left side actually. So ankle first, let's start with the stance phase actually. So the initial contact happens with the forefoot and midfoot, not with the heel in this kid. And there is no dorsiflexion happening in the mid stance in this kid if you go through the video actually. And coming to the swing, I was not able to appreciate any additional dorsiflexion. The foot clearance, it appeared to me as if it was facilitated by flexing the hip more and raising the pelvis. But I have to compare the anterior also. Coming to the knee in the stance, the initial contact appears to be happening in the flexed knee, and there is no extension happening at the knee throughout both the stance and the swing phase actually. There is a possibility of a stiff knee gait here. Compared to the hip, there is a constant flexion happening. There is no extension happening at any phase of the kid in this kid. And from the front, there is exaggerated foot progression angle, and definitely there is a break in the lever arm actually in this kid. So this is what I was able to pick up.
Good. Yeah. Thank you, Dr. Nirmal Raj. Hitesh, what are your additional features over and above what Dr. Nirmal Raj said?
Yeah, I agree with Nirmal Raj, but I have observed a few more points. Actually, the hip is adducted and interrotated left side, particularly more than right side. And what we observe is even though it's the patella and knee is going in internal rotation, the foot was external rotated. So we need to check about the thigh foot angle, whether it is the external tibial torsion or is it along with external tibial torsion, that would be mid-foot break. Because there is a clear-cut pictures, there is a heel doesn't touch it, and it was going in a mid-foot break. So there may be element of both tibia, left side tibia, as well as the foot. Along with that, what he said is that the first, second, third rocker of the foot and the hip and knee inflex.
Okay, we have another expert, Dr. Taral. Taral is like in a unique situation. The reason is because at present he is like looking at the video only, but he has a facility of 3D gait analysis at his center. So he's like you only, Ved, that he will be able to tell us something more. Taral, please.
Yeah. So, because it's easy to get carried away with 3D gait analysis report, we made a sort of a routine that we will in detail look at 2D first, get most of the information, and then switch over to 3D. Now, to get more information from a video analysis, there are two more things which are essential here. One is to see the video in a slow format, with a slow speed format, and also use freeze frames, stop video at particular section, so you can study what's happening, especially in mid stance phase and mid swing phase. You want to see things in more detail, so you will do a freeze frame. I agree with all the observations which have been done by Nirmal as well as Hitesh. Having done those observations, I'll tell you what I want to look for more information in a 3D gait analysis. I want to look at rotations of femur and tibia on a 3D gait analysis. I want to study the pelvic rotation and the foot progression angle. Because these are the areas which I think have a problem here, but I cannot make much interpretation just by looking at the videos. One more thing I want to make a sort of would like to see in detail on 3D analysis, the peak knee flexion in the swing phase, because on examination you have prone rectus test positive. The child has fixed knee flexion in the stance phase, which continues in the swing phase, and you don't see the knee flexion which is required for clearance. So rectus may be tight here. So so there are some information which we have got from 2D. The balance is good. The child is EMFCS 2 almost, or better than that. And with that and combination of clinical evaluation sets the stage for interpreting a 3D analysis. You will not jump directly to 3D graphs or interpretation. Thank you.
I think those are great points. I love the idea about thinking about looking at it with 3 screens and video. It highlights my point is that a really high quality video analysis gives you a lot of information. But I love your points too. It highlighted exactly what I said. The two big areas that the 3-dimensional gait analysis really is a confirmatory type study is transverse plane and rectus dysfunction. I like that.
Before we move on, I would like to ask Hitesh a question. Now we identified that there is a transverse plane abnormality. It could be from the foot, it can be from the tibia, and it may be compensated by femur to some extent. So what do you do next? Do you rely only on clinical examination, or do you go for the CT scan torsional profile assessment? Because you don't have a 3D gait analysis. So
gait analysis. Yeah. Thank you. Actually, I do a lot of clinical examination, but whenever in doubt, wherever there is a complex situation like a miserable malalignment, then I don't hesitate to do the CT scan, because it will give you the idea about the version of the femur, that is internal rotation, and that would be the external rotation of tibia. Okay. So the most of the time I try to take the thigh foot angle and the version by the Craig's test and internal rotation of the hip and external rotation of the hip.
So now what we will do is we will go to next step, and I will show you the 3D gait analysis report to Ved. And Ved, you just need to tell us more about what these experts are not able to identify on the video. You have to identify on the 3D gait analysis. So I'm showing you the report.
I was pretty impressed. They got everything that I saw on the video. So we'll see what the gait analysis then shows.
Yes. Yeah. Okay. So here is the kinematic data of the patient. The red is left and the green is right. So let's see. Are you able to see it well?
I can. Can we make that a little bigger? Can you expand that?
Yes, I can do that. I can do that.
Or actually make it smaller.
Okay.
Just so we can see a little bit more of the screen. I couldn't see the top of the plots. There we go.
Yeah. So let me just move my screen and
So this is these are plots of the gait cycle from zero. There we go, from 0 to 100%. And then the scale on our y-axis is in degrees, and it changes based on what we're looking at. The gray plots are typically developed our normal controls. And so, you know, roughly, if you just look at this, is the pelvis looking at across the board. There's really not a really significant pelvic obliquity. Both, if you look at, it's most of those in the gray plane. So we're not getting a lot of coronal pelvic issues from limb difference or from perhaps of scoliosis or fixed pelvis from that. Our pelvic tilt, we have our typical double bump pattern there where we are showing some increased anterior pelvic tilt. That is fairly classic when we have someone in a hip flex and crouch gait position for there. It does dip down into the high end of the normal, but most of the gait cycle, you can see that it is an increase in pelvic tilt. And this child has had hamstring lengthening once in the past, I think, right? Our pelvic rotation, and again, red is right. Is that correct?
No, red is left. The
red
green is
left.
right.
Green is right. Yeah. All right. So you can see we've got some left pelvic retraction at initial contact. And it basically that pelvis stays mostly retracted, rotated backwards throughout the gait cycle. And so in my mind, I'm concerned about that there's going to be some internal femoral rotation with that. And so the pelvic, obviously on the other side, it goes back.
Okay, so you gave us two more information that there is a double bump pattern in the sagittal plane. And yes,
Right.
There is a pelvic asymmetry or the retraction on the transverse plane. Okay,
and
so
it's small. If you look at the scale, right? I mean, it's 5 to 10 degrees,
yes,
and that's something that's very, very hard for us to visualize. That. So I think that is one thing that, you know, is not surprising that's something that we see on this.
Okay, so now we have more about the hips.
So again, as we expected, there's hip flexion really throughout the gait cycle. The hip doesn't come anywhere near to that extended position in mid and late stance. There's not a lot of significant adduction. So probably a lot of what we were seeing a little bit that could have been was apparent adduction from this internal rotation that we see down here. And so it's not horrible. It's not severe, but it is there where she has bilateral hip internal rotation. It's fairly symmetric actually between left and right, but for whatever reason, she's compensating more for that left-sided internal rotation with her pelvic retraction for that.
Okay, so basically, like we are not getting more information on the hip side, except yes, the hip remains in flexion.
It confirmed. I think this confirms it a little bit. There were definitely gait cycles that I thought she looked like she was a little internally rotated. I think that confirms it there.
Okay, so this is about the knees.
Yeah. So first of all, the knee varus valgus, I think we use that as mostly a control plot for our marker placement. I mean, most of the time, as you can see in your typically develops and your controls, there shouldn't be a significant amount of knee varus valgus. And so if we see something off a little bit, that kind of just makes us worry a little bit about some marker placement. It's very common to have, you know, even a small little deviation in your marker placement might give you a little bit of a plot like that. So just something to keep in mind about it. Our knee flexion definitely shows that she has really significant knee flexion throughout the gait cycle. She's got increased knee flexion at initial contact and in mid stance.
The next question which I would like to ask, like on clinical examination, there is a 20-degree flexion deformity.
Right.
What we see on the kinematics data is like the knee flexion during the stance phase is much more than the 20-degree.
Absolutely.
So,
she's not coming to the end of her range of motion, right? I think that's something that Freeman really taught us to do. If she had enough control that she was coming to that end of motion minus 15 degrees or so, I would be much more comfortable about her knee sagittal function. But because she's not going to there, that's probably due to her quad weakness. And we saw a little bit of that with her extensor lag on her physical exam.
Right, but even that was a 20 degree of extension leg, but this is even much more than that.
Even more than that, right?
Okay, and then we go to the foot part.
So then the rotation, there was there was some folks thought that he might have had some external tibial torsion. I think we see that on that knee rotation there as well.
Okay, and this is about the ankle.
Dhiren, can I comment?
Yeah,
So
please.
extension lag does not translate into knee flexion in stance phase, because when you do extension lag, the gravity is not acting. There is
Exactly.
no body weight acting in, which is trying to get the center of gravity down. It's not acting. So
That's right, but it is more.
Have to be, yeah.
It's more an
It is
initial
more.
contact, right?
So
Yeah,
that
initial
suggests that there
contact.
is some quadriceps weakness over and above the flexion deformity.
And anti-gravity weakness, that
Anti-gravity
the
weakness,
mechanism to keep the body upright is not working to its optimum.
Yes, exactly.
And on the contrary, if the extension lag and the graph on gait analysis is same, you know that the muscle control is good.
Right.
Okay, and then how do we look at this ankle kinematics?
Yeah, I think, this shows hyper dorsiflexion, really, especially there on the right side. But I think what we're seeing is what was mentioned before. This is likely measuring our midfoot break. This is a single segment foot model that really can't distinguish between midfoot break and true dorsiflexion. So, that is a pitfall of looking at these plots without recognizing that. That certainly goes back to your physical exam. We know that there's a bit of plantar flexor tightness. We know we have a plano-valgus foot deformity, and this is very typical when you see that.
Okay, but in that case, like we know that there is a midfoot break. So in that case, do you disregard the ankle kinematics completely?
Mostly, yeah. Mostly.
Fine. So let's go to the next part. Where the time is over, are you comfortable for
I've probably got another 5 minutes before I got to head into the
okay.
operating room.
Right. So this is where the kinematics data is. And can you tell us more about additional information which we are getting?
Yeah, so if we scroll down just a little bit, I like this so we can see this. We can see the kinematics above, and then the kinetics are right below it. So I think if you see both of those was my point that I broke before, and you look at the scale of this, these are significant knee extensor moments through here, because normals are down in the gray. So it's exactly what we said before. There's a lot of internal extension moments that are having to counterbalance that ground reaction force that is causing even further knee flexion because of the overall plantar flexion knee extension couple issues.
So what is your impression from this? Let me first of all show you the ankle.
The powers.
Kinetics, their power.
Yeah. So she's, she actually, as we said, she's really quite functional. And looking at this qualitatively, she's able to generate fairly good propulsion with her ankle power and fairly good with her hip power. So I think she has the potential for really normalizing a lot more of her hips a lot more of her gait function by us trying to take care of some of these impairments.
Okay, would you like to see something more, which is not really probably, this is the ground reaction force.
Yeah, I think that's what we'd probably expect for that. Yeah.
Right, and then there is a vertical displacement, which is not okay. So basically now the question is, what more information we obtain from the 3D gait analysis, which really helps us to change the line of treatment. I have not asked about the plan of Dr. Nirmal or Dr. Hitesh, but we would really like to understand what more information we obtain from this, which will help us to change the plan.
I guess there's a couple of things. I think it confirmed our transverse plane suspicions, right? So that might have fallen underneath someone's radar about whether they need to address that or not. I think, you know, the external foot progression angle and the plantar flexion knee extension couple, the fact that, you know, that the feet and the tibia are externally rotated and the feet are flat, I think that is contributing a good bit to her knee flexion. And so, you know, I think that is probably something that we saw visually, and we obviously would need to consider that. I think the transverse plane kind of makes me pause a little bit because we were suspicious that there was some femoral rotation. And I think the key thing is that then we were confirmed by the gait analysis. And now we need to kind of circle back that up to the family and see, is the femoral rotation big enough, and that is it causing enough of an impairment that we would need to address it. The other thing that I would just say is that the kinematics were quite impressive for me, and it's concerning. And she's already had a hamstring lengthening once, and she's already got a little bit of an anterior pelvic tilt. So I would be a little concerned about trying to do any other type of revision soft tissue surgery, that I just would be concerned that it may not be effective enough to try to bring her back down into more extension, intersagittal plane interview.
Okay, already we are 6 minutes over time. So, and you have a case waiting for you in the OR. So we will end the session, but I request you to have one more session with us, because we have still 7 or 8 more questions, and we would really like to understand about those questions also.
I'd love to do that. That would be a lot of fun. This was great. Thank you so much for having me.
Thank you very much on behalf of all the fellows and all the directors of fellowship. See you soon. Thank you.
Thank you so much.
I'll just make a last comment. Don't depend on gait analysis to provide answers, because it will raise more questions than providing answers.
Yes, that's what we want to understand.
It does provide. I totally agree. I think the fundamental and the foundation should be your clinical exam. Absolutely.
Right. Yeah. Thank you. Bye-bye.
Bye. Thank you.
Bye. Thank you.
Thanks.